Welcome to Boston Children's Answers Parentcast. I'm your host, Jennifer Arnold. As a doctor and a mom, I'm passionate about helping kids stay happy and healthy. So join me as I chat with other Boston children's experts to find answers for you and your family. Hi there, and welcome back. Today we're going to talk about an important part of the body, the ACL. It's a part of the knee that when injured can really impact kids, especially active kids. As always, let's start off with our parent question.
Hi, I'm Julie. Both my kids play soccer. Becca's 14 and Patrick is 12. Last year, 2 of Becca's teammates had ACL injuries. How can I help my kids avoid that?
Thank you so much for that great question, Julie. Unfortunately, ACL injuries are common in our kids, and oftentimes they lead to interruption in sports and really the activities that our kids want to do. So today I am excited to explore ACL injuries and how we can prevent them with our guest expert, Dr. Mininder Kocher. Dr. Kocher is an orthopedic surgeon and also the chief of the sports medicine division here at Boston Children's Hospital. Welcome, Dr. Kocher.
Thank you, Dr. Arnold. It's a pleasure to be with you.
I typically start off every conversation with our experts asking them how you got into your specialty. So I'm curious, what drew you into orthopedics?
I got interested in medicine and eventually orthopedics because of my own injury when I was in high school. I tore my meniscus playing basketball when I was a sophomore in high school. I grew up in Rochester, New York, and saw Dr. Ken DeHaven, who was a real mentor, who became a real mentor to me. But he diagnosed it and did surgery, and I was able to get back to playing basketball in high school and actually played for 2 years in college. And so for me, just that ability to, see someone injured and make a diagnosis and fix it and get them back to what they love doing had a big impact on me. I think for me, it's come really full circle. I have a number of patients who've given me their essays about how their injury has led them to an interest in medicine or orthopedics or physical therapy. So it is really very personal and very relevant to our conversation today.
I really love that because I do think for many of us in medicine, it's our life experience that kind of pushes us into the fields we go into. Growing up, I had many surgeries and I actually thought about orthopedics, but I figured it would be pretty physically demanding, so I picked another specialty.
Well, we would love to have you in orthopedics.
Thank you.
I think it helps you understand a little bit about the patient perspective and kind of what their goals are and where they're kind of coming from if you've been in that on the other side of the table. Exactly.
You have a lot of empathy. I think you really can help your patients because you've been there, and I think it makes you a much more compassionate doctor. So that's awesome.
Yeah, good point.
Maybe we should start off, in case our audience doesn't know, what the ACL is and what it does in our body.
So the ACL stands for the anterior cruciate ligament. A ligament connects bones. In this case, the ACL goes from the femur bone to the tibia bone. It's one of the 4 main ligaments in the knee, and it's actually the primary ligament. It runs right through the middle of the knee. So it helps to give stability to your knee so you can do cutting, pivoting, jumping type sports. Also, so your knee is stable so you don't start to tear and chew up other stuff in the knee like the smooth cartilage, the articular cartilage, or the shock absorber cartilage, the meniscus cartilage.
So it's a pretty important ligament in our body. I have been told that mine is not in the right spot, so but it works so far. So tell us a little bit about ACL injuries. What are they and how do they happen for kids?
Yeah, an ACL injury typically happens during sports. It can happen, during other activities as well. And basically there's enough force to rotate the knee that overcomes the tensile strength of the ACL, and so the ACL ruptures, it tears. The 2 most common mechanisms of injury that we see are called non-contact pivoting. So that's where you're cutting, pivoting, twisting your foot, and that rotation tears the ACL. Or a contact injury, that would be like you get tackled in football or soccer, and that external force tears the ACL.
Are there any particular, like you said, activities or sports that are more predisposed to an
Yeah,
injury?
I think we can see ACL tears in almost every sport. I think the most common sports in the U.S. where we see ACL tears are soccer, football, basketball, things like skiing, but we can see tears in other sports as well, lacrosse, tennis, skating. Interestingly, we don't see a lot of ACL tears in dancers. We see some, but not a lot. I think that leads to some of our thoughts in terms of ACL prevention. But I would say probably the big ones are football, soccer, basketball.
And when you tear or injure the ACL, what are the different levels of severity of ACL injury?
You can have like a sprain of the ACL, meaning the ligament is swollen, but there aren't any tears of the fibers of the ligament. You can have a partial tear where the ACL is partly torn, but part of it's intact. Okay. And then you can have a complete tear where the whole ligament is sort of exploded or torn. Beyond that, you can have multi-ligament injuries of the knee. So in addition to the ACL, you may tear another ligament like the MCL, the medial collateral ligament on the inside of the knee, or the LCL on the outside of the knee, or another ligament called the PCL, which crosses the ACL and goes in the other direction.
Oh, wow. With the ACL, when you say a tear partial or complete, is that going along like, up and down? It separates in the middle, or is it coming off of the tibia or the femur when you say tear?
Yeah, it's a really good question. So I think most of the partial tears that we see are kind of perpendicular to the fibers. And so part of the ligament's intact, part of the ligament's torn. But we can see the most common ACL tears we call mid-substance. It happens right in the middle of the ligament. But we can see proximal tears that come off of the femur. Or distal tears that come off of the tibia. And then actually one of the injuries we can see in children, we don't really see as much in adults, is called a tibial spine fracture. And that's where the ACL inserts on the tibia. In younger children, the ligament may actually be stronger than the bone. So instead of tearing the ACL actually pulls off the bone from the tibia.
Wow. That must be definitely not very comfortable.
No, that's pretty painful because you have a fracture in the joint, so you get a lot of bleeding and swelling. Interestingly, I think the dogma was sort of that kids didn't really tear their ACL. They got tibial spine fractures. In the 1990s and certainly by 2000, we started to realize kids also tore the ligament as well, and now we see that more and more frequently.
Wow. So, yes, it sounds pretty complicated, all the different types of injuries. You said that a complete tear is most common. Are ACL injuries in general pretty common? And are we seeing more of them today? Because it feels like to me we're hearing more about them in kids than maybe when I was growing up.
Definitely we're seeing them more commonly in general, and we're seeing a real spike in ACL injuries in children and adolescents. In the U.S., there's approximately 200,000 to 300,000 ACL tears a year. We've done some research where we looked at the database of children's hospitals in the U.S., and we found from 2000 to 2020 a 5-fold increase in ACL tears in children and adolescents. So we're definitely seeing them more frequently. And that's not only in the U.S. There have been studies done in Norway, Australia, and New Zealand that are also showing a steep increase in the number of ACL injuries in children and adolescents.
Wow. And are you seeing any difference in terms of, ages or maybe differences related to gender?
We're seeing a real high risk in adolescent athletes, particularly female adolescent athletes who are participating in a cutting, pivoting sport. Like female high school basketball, soccer players have a 3 to 5-fold increased risk of tearing the ACL than the male adolescent athletes. And then we're also seeing more ACL injuries even in younger children, so prepubescent children who've not hit puberty yet.
Any thoughts as to why that might be?
Yeah, I think part of it is that we're recognizing that the kids get this injury, so we're more likely to have it in our list of possible injuries. We're more likely to order an MRI to look for it. So I think that's a bit of it. But I think the bigger part of it is just the way youth sports has changed. Kids are playing at a higher intensity at a younger age. They're focusing on a single sport, so early sport specialization at a younger and younger age. They're playing that sport year round. They're playing lots more games and tournaments that has a much higher risk of injury than practice, maybe 5 to 10 times higher. And then I think kids are getting, they're maturing earlier. So kids are getting bigger earlier. They're able to generate more force in their knees. And so I think all of those things kind of, play a role in the increased injury rate that we're seeing.
It's almost like sports are becoming more serious.
Yeah, I think serious is an interesting word. I tend to think of it as getting more professionalized, right?
Yes.
So there's a lot of involvement in parents and coaches and tournaments, and the youth sports industry is actually a really large industry. And if you include travel and tournaments and time away from work for parents, there's a lot of money involved. And I think as the kids, start to approach sports more like a professional athlete might, they're losing a lot. Like I think kids have lost a lot of free play. They've lost a lot of sport sampling, meaning trying different sports or playing a different sport in a different season. I think a lot of those things can actually help reduce injury rates.
That's great. It's important for parents, I think, to think about as they're supporting their kids in their sports goals, how to make that balance. That's important.
I think it's hard from a parent point of view. I mean, we have 5 kids who've all, played sports, and a few of them have played sports in college. And, I think as a parent, you may not be wanting your kid or thinking your kid's going to be a professional athlete or even play in college, but even now, just to make the high school team, they really have to kind of play on a club soccer team and play at least 3 seasons. And so I think, we're all sort of swimming upstream in the current environment.
Yeah, I've got 2 early teenagers. I'm just sort of learning what that environment's all about. So why are ACL injuries more common in girls?
Yeah, it's an area of real interest and real research. I think there are multiple factors. Some of them are anatomical, and so the ligament itself, the size of the ligament proportional to the size of the knee, is smaller in females than males. The space where the ACL lives in the middle of the knee, called the notch, the intercondylar notch, is more narrow in females than in males, and so that puts the ligament at risk. I think some of it is what we call neuromuscular, which relates to kind of how females jump and land and move. And so I think many studies have shown that females, when they land a jump, their knees are straighter instead of more flexed, so that doesn't absorb the energy as much and can transmit it to the ligament. I think there's often the foot might be planted longer on the ground when you're twisting and pivoting. That transmits more of a rotational force across the knee as well. I think there are some muscular differences. So in general, lower body strength is lower in females than males, but there often also tends to be more of a muscular imbalance, with the quads being stronger than the hamstrings in females, and that puts the ACL at risk. So when we work on ACL prevention, we look a lot at that quad hamstring ratio, trying to strengthen the hamstrings. And there are even some data that show that the risk of ACL injuries in female may vary depending on where she is in the menstrual cycle. So there's certain hormonal factors. We know there are hormonal receptors on the ACL that may play a role as well.
So many factors that kind of come into play with these injuries. Knowing that these are so common, what are the symptoms to be looking out for?
Usually there's an injury. Again, that could be a non-contact twisting, pivoting type of injury, or that could be a contact injury. Many of the patients, I'd say over half of patients who tear their ACL, feel or hear a pop in their knee. When the ACL tears, it then the bleeding goes into the joint, but now you have a swollen knee.
Well, yeah, so swelling, popping, potentially, and pain, I imagine, too. So I guess if you're suspicious, as a parent, or you take your child into the doctor to get evaluated for a potential ACL injury, what are some of the things that you do to help make that diagnosis?
Yeah, I think the first point is to get your kid into the doctor to get it seen. That phrase "no pain, no gain" that really bothers me in youth athletes, because if they have pain or if they've had an injury, it really should be sort of checked out. I think once we're seeing the patient, we're taking that history as well. And then on physical exam, we're looking for a swollen knee. We're checking what the range of motion is. We're tugging on the knee to check the ligament stability. And then, so if we do a test called the Lockman test, where we have the knee bent about 20 to 30 degrees and we pull the tibia forward, if there's a lot of motion, that's a sign that the ACL has been torn. I think in kids and adolescents, it's really important to do that same test on the other knee, the uninjured knee, because kids often can be just kind of flexible and loose jointed. That's how they are. And so you may feel like that knee feels loose, but when you go to their uninjured knee, it's the same looseness. So that may not be an injury. That's just kind of their underlying laxity.
So being able to differentiate that is really key.
Yes.
And then after that exam, how do you confirm the diagnosis?
Well, we typically get x-rays. In x-rays, we can see an injury like we were talking about, a tibial spine fracture. That's where the ligament's not torn, but it pulls off the piece of bone. So that's something we would see well on x-rays. Also with x-rays, we can get a sense of, whether their growth plates are open and how open their growth plates are. Typically, if we're suspicious of an ACL tear, we're going to proceed to an MRI scan.
Okay.
And an MRI scan will give us much more information about, whether the ligament's torn, what's the grade of the injury, what are the associated injuries, like a tear of the meniscus, the shock absorber cartilage, or an injury to the articular cartilage, the smooth cartilage in the joint.
I just want to kind of come back to your initial statement about bringing your child in, is the first key step, because kids should not live with pain, and, not to ignore that. I think that's really valuable, very practical advice to be reminded of. So,
yeah, I think it's a really important point, particularly with overuse injuries, and so we see, kids who've had knee pain for 6 or 9 months, and now the pain's worse or the knee's locking up, so they finally come in. One of the overuse conditions we see in the knee is called OCD, osteochondritis dissecans. That's where the bone and the cartilage can start to separate from the underlying bone and cartilage. But it often presents just as sort of vague knee pain early on. But if we catch it early on, we can do things like physical therapy, modify their activity, and it will heal on their own. If we don't catch it until now, there's more swelling and locking, it's unstable. Now it needs more complex surgery to fix it. And so I think catching these things early, often we can treat without surgery with a really good outcome. But sometimes we don't see them early because of this kind of no pain, no gain mentality.
Yeah, no, that's really important, so that, catch it early, and hopefully that means the treatment will be, less extensive.
Yes, for sure.
Great advice. So again, now your area, when you see kids, once you have that diagnosis, how do you treat ACL injuries?
Yeah, I think it depends on the grade of the ACL injury. So those injuries that are a sprain where the ligament's not torn, we can treat that without surgery. We do physical therapy, a brace, keep them out of sports, and typically it heals and they can get back to sports at 3 months. The ones that are a partial tear, we've done some research, and about 70% of those patients can do well without surgery. About 30% will go on to need surgery. I think when it's a complete tear of the ACL, that's probably the most common presentation that we see. We are usually recommending surgery if the patient is young and active. I think, again, back like in the 1990s, early 2000s, the thought was if you had a complete ACL tear in a child with open growth plates, you'd treat that non-surgically, wait till they were older and their growth plates were closed, and then do surgery. We've studied that, and I think that's a really poor option because it's really hard to take a kid out of sports and activities. They tear their ACL at 12, and you say, okay, we're going to keep you out of sports till you're 16 and then do surgery. That's a big hit to the kid and the family psychosocially, their friendships, their identity.
Yeah.
But also the knee's very loose and unstable, so they go on to tear their meniscus or cartilage. Now they're at increased risk of arthritis in the future. Now that we've developed better ways of doing surgery in kids with open growth plates without having growth issues, growth disturbances, I think the treatment option for a child who's active who tears their ACL should be surgery.
Along those lines, what are the different types of surgeries that you typically do?
Yeah, so it depends really on the age of the child. And this is where, we know what the patient's chronologic age is, but we also want to know what their skeletal age is, their bone age, because we all know, some early bloomers or some late bloomers. We want to get a sense of how much growth they have remaining. We often do that with a X-ray of their hand to look at their bone age or to look at them in terms of their Tanner stage and think about where they are in adolescence and pubescence. When we have young kids who are prepubescent, who have a lot of growth remaining, we have surgeries where we can reconstruct the ACL without drilling through the growth plate. So here at Boston Children's Hospital, we innovated a surgery where we use a portion of the iliotibial band as a graft, that is tissue, to reconstruct the ACL. It's both extra-articular, so the IT band outside the knee, and then intra-articular, the IT band going through the knee, and we fix it to the bone without drilling through the growth plate. So we call that a physeal sparing or growth plate sparing ACL reconstruction.
Which is really important for a child who's, not done growing.
Absolutely, because we want to stabilize their knee, but we don't want to risk a growth disturbance. That would be where the leg grows short or it grows off at an angle, which could be sort of a major complication.
Yeah.
But we've studied that technique in prepubescent children where we really have excellent results, an over 90% rate of returning to sports, a re-injury rate, so re-tearing the graft and needing another surgery in the future, which is really quite low, about a 6% chance, and we haven't had cases of a growth disturbance where the leg grows shorter or grows off at an angle.
Which is so important. Yeah. Wow.
And then in the next group, the adolescent group, so these are now kids that have hit puberty, but their growth plates are still open. So these are typically 12 to 14-year-old girls, 13 to 16-year-old boys. In that patient population, we do drill. So we drill across the growth plates to get the graft into an anatomic position. But we use a soft tissue graft, so a graft without bone. That's typically hamstrings or quadriceps tendon. We use that tissue to replace or reconstruct the ACL. We drill across the growth plates, but we drill at certain angles to minimize the cross-sectional area across the growth plates, and then we fix away from the growth plates so the growth plates can continue to grow. And we've studied that in our patient population as well, and we're able to do that with minimal risk of a growth disturbance.
And I'm thinking, just in case our audience doesn't really understand growth plates very well, those are the areas of the bones, the ends of the bones, right, where there's rapid growth of the bone, essentially the cells that make up the bone. And a disruption, if you were to disrupt or injure that area, during the puberty or just general growth of a child, it could end growth there, and that's where you get to what you were describing, an abnormal path for growth.
That's a great description.
Okay.
Yeah, so
Okay.
you're right on. So the growth plates are how the long bones, like the femur and the tibia, grow. They're at both ends of the bone. They're really made of cartilage, and then that cartilage grows and turns into bone. Those growth plates are typically open in girls until about age 14 and boys until about age 16. And so the problem is when we're operating on the ACL, we're very close to the growth plates. And so it's very important, to respect those growth plates so you can reconstruct the ACL and get a stable knee, but those growth plates continue to grow so you don't get a leg length discrepancy or an angular deformity.
Very important. Well, any other surgeries that you wanted to share that you all do?
Yeah, I think, we talked about the young patients, prepubescent. adolescent patients who are, still have open growth plates. And then we see a lot of older adolescents whose growth plates are really closed. And in that scenario, we can treat the ACL injury, just like an adult ACL injury, where we can use hamstrings or quadriceps tendon, but we also can use a patellar tendon graft, the patellar tendon with some bone from either side. Another graft option is allograft. That's using tissue from a donor. But we don't like to use allograft in younger patients because the failure rate, the risk of the graft tearing and needing another ACL surgery is much higher than using the patient's own tissue. I think other options that are kind of newer include doing lateral procedures. This is called LET, lateral extraarticular tenodesis, and this is in addition to reconstructing the ACL, using a portion of the iliotibial band outside the knee to give additional rotational stability and reduce the risk of re-tearing. There's more and more data showing that can reduce the risk of re-tearing, particularly in high-risk populations like adolescent athletes going back to cutting and pivoting sports. Another approach is actually repairing the ACL. So instead of ACL reconstruction, which is the most common surgery, that's where we replace the ACL with new tissue that becomes the new ACL, trying to get the patient's own ACL tissue to heal.
To repair itself.
To repair itself. And that's a big innovation out of Boston Children's Hospital with my colleague, Dr. Murray, called the Bear technique, where you put sutures in the remnant of the old ACL and use an implant, a sponge implant that's injected with whole blood, and that's to try to stimulate the ACL to heal instead of necessarily reconstructing the ACL.
Wow, that's also pretty phenomenal and exciting to think about too as another option.
Exactly.
So sounds pretty complicated in terms of all of these options, and I would imagine that it's really important for patients and families to go to, a pediatric orthopedic surgeon who has expertise, especially given the complexities of different stages of their growth, so that all of these options can be explored. How do you choose the right one for an individual patient?
Yeah, it's a great question. I think, I think it is very important in this patient population to have training both in pediatric orthopedics and in sports medicine. So for the 8 sports medicine surgeons in the sports medicine division here at Boston Children's Hospital, we've all done a residency in orthopedic surgery, but then a fellowship in pediatric orthopedics and a fellowship in sports medicine. I think that really helps in terms of understanding growth and the growth plates, because it's really dynamic. The knee's not static, it's growing. You're doing a surgery sort of on a moving target. So, my advice to parents when they're facing this situation is, to look for a sports medicine surgeon who also has training in pediatric orthopedics, to talk to them about how many surgeries do they do in kids this age. Talk to them a little bit about their experience, and then at the end of the day, I think as parents, we have a gut feel about, who has the expertise, who has a good bedside manner. So who connects to that patient, what does the kid think in terms of the surgeon, particularly, if they're an adolescent, how they've connected to the surgeon.
So speaking a little bit about sort of that, care of the whole patient, the mental and the physical health. Tell me a little bit more about, from a mental health, how you support our patients.
Yeah, we really think about the patient holistically, both psychologically and physically. And I think that the tearing an ACL in an adolescent patient is a really big psychosocial impact. These are kids that are, identify as adolescent athletes. That's sort of their identity. That's their peer group. And so when you get injured and you have to have surgery and you can't get back to sports for 9 months and you lose your peer group and your identity, for some patients, it can be a really big impact. We have our sports medicine behavioral health clinic, where we have psychologists and social workers who are really good with working with these patients. They've got good strategies to help with coping. Sometimes there can be depression or adjustment disorder that they can help with. I think even when we're now returning back to sports, there can be a fear of re-injury that they have to overcome. And so having our behavioral health sports medicine clinic can really help these patients with those aspects of recovery.
That's really great to hear. I think, today more than ever, we're having more and more attention towards the mental health impacts of the physical health issues that we might be focused on originally. I mean, growing up as a kid, all of my time in the hospital, there was very little thinking about the mental health along with the physical health. So it's great to hear that we're embracing that here, and I'm sure it's spreading more and more as across the nation. So that's exciting.
Yeah, I think it really is.
How do you manage the pain aspects?
We've come a long way in terms of pain management after ACL surgery. I think, traditionally it's been a general anesthesia during surgery, and we prescribe narcotic pain medicine after surgery. The problem is that it doesn't really control pain that well, and there's a lot of concern from parents and from our patients about, developing an addiction. So we've collaborated a lot with our anesthesia colleagues, and now our approach is really one of regional anesthesia. This is where the anesthesiologist can do an injection around nerves, or they can even put a catheter around nerves, and that numbs up the knee after surgery. That can last, up to 12 hours for a single shot, or 2 to 3 days with the catheter. And what we've found is that the patients have much better pain control. They don't use any, or if they do, they use minimal narcotic pain medicine. And then they can really get on their physical therapy earlier. They can get their knee moving earlier, which can help prevent stiffness and other problems down the road.
Yeah, no, it's great. I think we've definitely come a long way in pain management. It sounds like that's working really well and has a much better experience for kids, because that's got to be scary, all that pain to deal with too.
Absolutely.
It's not just the injury, but then it's the treatment too.
Yes.
So I'd also love to dive a little deeper. We're seeing higher numbers in kids and adolescents. What can we do from an injury prevention perspective?
It's a bit challenging, honestly. I think we actually have ACL prevention programs that have been well studied scientifically, and they can reduce the risk of injuring the ACL by 30 to 40%.
Wow.
So they're really effective ACL programs. It's hard to get the programs out in the community for uninjured kids. So you'd have to work with schools and youth sports organizations and coaches, and they often don't want to do the dynamic training and warm up and balance. They just want to get out there and start playing their sport. So that's been a bit of a challenge. Also, insurance pays for injuries. They'll pay for your surgery, but they don't really pay for prevention and for training. And so that's another hurdle. I think once we typically are working a lot on prevention once we're taking care of a patient, we've reconstructed the ACL, now it's 9 months after surgery, we're returning to sports. How do we prevent re-injury in that knee or injury to the other knee? That's a real focus of the McKaylee Center for Injury Prevention. We have one in Waltham and one in Norwood. And in ACL injury prevention, we're working a lot on neuromuscular control. Okay. And so that is, how do you land a jump? Are your knees bent? Are your knees over your ankles, or are your knees going inward? That's called dynamic valgus, because when your knees go inward, like knock-kneed, that increases the risk of injury to the ACL. So we train jumping, landing, keeping the knees over the ankles. We look at their muscular strength, trying to balance the quad and the hamstring. Often the quad is much stronger than the hamstring. We look at their hip strength, their hip abductor strength. We look at their alignment. Are they flat-footed and pronated, which can drive more of that valgus? So these are some of the things that we're working on with ACL prevention. And then when they go back to sports, doing a dynamic warm-up before they go out and play sports. A good example is a dynamic warm-up program for soccer called the FIFA 11 Plus. So you can go and look this up online, and it's been very well studied scientifically, and reduces the risk of injury up to 40% in soccer athletes. It takes 15 minutes to do. So if we can have our athletes do this before they go out there and start practicing or playing, I think these are prevention aspects that are really important to focus on.
Yeah. So even for kids maybe that haven't had an injury yet, but for a parent listening who says, I want to be able to prevent this if possible for my child, the training and making that part of your, daily regimen or your sports regimen is to do these things that can help, decrease the risk from those risk factors.
Absolutely. I give a lot of talks on ACL injuries and ACL prevention. And I was at one conference and I was actually asked to give a talk on creating ACL injuries. And I thought for sure that was, a typo.
Yeah,
like
mistake.
You want me to talk about ACL prevention, but they actually wanted me to think 180 degrees opposite. Like, how would you design a program to create ACL injuries? And I think thinking this way can help us in terms of actually prevention. And so what I came up with was you would take like the highest risk group of athletes, which were kind of adolescent females, put them in a really high risk sport like soccer, make them play games instead of practice, and make them play multiple games so that they're fatigued. Wow. And turns out that's like what a soccer tournament is. That's what these kids club soccer are doing every weekend.
Oh my
goodness. And so in a weird way, these tournaments are designed to create ACL injuries. But what we can learn from prevention there is a little bit about, fatigue and the risk exposure in games and thinking about prevention when we're in these settings that I think can be very useful.
Yeah. I mean, you just talked about the way you structure like a season, right? In terms of maybe the number of games per practices. And you talked about sort of like how you prepare the individual with their training to help prevent. So lots of things that we can do maybe to help decrease the risk.
Yeah, I think so. And I think for those things that are really structural, I think it's not just us. We really need to partner with youth sports organizations and coaches and policymakers to really start to think a little bit about how we've designed youth sports.
Knowing that there are things we can do today, how early should you start some of these actions to help prevent ACL injuries?
Yeah, it's an interesting question because the peak age incidence for ACL injuries in the United States is age 16 to 18. So that's where we're seeing the most ACL injuries. So I think if you want to really work on prevention to decrease that peak, you have to go earlier. So that would be early adolescence or even sort of prepubescence. I think that is like from what we were talking about, working on balance, jumping, landing, muscle imbalances, the neuromuscular control. But it's also thinking about sort of the more structural things like, are the middle schoolers, are they focusing on a single sport? Are they playing that year round? If you're doing that, you're not developing other muscles, so that puts you at increased risk of injury. It's actually interesting when we get the prepubescent children into the McKaylee Center for Injury Prevention and work on things. They may be very good in their sport, but they're actually quite weak or they don't have good balance in some things. And a lot of the things that we do with prepubescents, I think they actually might have got when there was more free play, right? So we have them like working on their balance, but they would be doing a lot of balance activities in free play. We have them like climbing things to work on core strength, but they would have been, climbing things. And so
in the playground or something.
Absolutely. But I think that free play aspect is kind of gone. But I actually think that the prepubescents learned a lot of things that can help with injury prevention when they were doing less structured sort of free play.
Again, it sounds like prevention is key, but also earlier is better so that you develop those habits into your daily life.
Absolutely.
And we don't lose that. That's great. So as we near the end, one of the things I love to learn about is what kinds of research are going on, either at your center or, in general, that are really important to be aware of.
Yeah, I think this is a big focus of the ACL program was clinical care, but also research to improve that clinical care and to improve outcomes. So we're doing a lot of research in terms of like better diagnosis of ACL tears, imaging, surgical techniques, to improve care, ACL prevention. Some of the big studies that we're doing, one is called Pluto, Pediatric ACL, Understanding Treatment Options. This is a multi-center study at 10 pediatric sports medicine centers across the country, and we're the primary center. So we have 800 children and adolescents, all with open growth plates, who've been treated with ACL surgery, 4 different techniques. And we're following these patients forward in time to look at their return to sports rate, their knee function, their risk of re-injury, and to follow their growth. And so these patients are now minimum 5 years from their surgery. So we're getting a lot of really interesting data from following the outcomes on these patients.
That's exciting.
Yeah, it's exciting.
Especially since we were talking about, like, there's so many different surgical options, and how do you, make that decision on an individual child? This sounds like it's going to really help with that.
I think it will. We had a IOC, International Olympic Committee consensus meeting in 2017 on pediatric ACL injuries, and we reviewed all the literature, and our main finding was that we needed prospective data, so where we follow the patients forward in time and we have high rates of follow-up and things are done in a systematic way, so we have better quality data to make treatment decisions. So that's really, one of the main reasons we started the Pluto study.
That's great.
We have other studies on techniques like the Bear technique that was pioneered here by Dr. Martha Murray, in terms of trying to get the ACL to heal instead of reconstructing the ACL. We have the Saturn study, which is taking the ACL technique that we developed here using the IT band in the young prepubescent children, but now applying that to older patients, adolescents, and even skeletally mature patients to see the outcomes. And then we have studies, based on what we were talking about before, the psychosocial aspect of ACL injury. We have a study called ROAR, where we're looking at patients who've torn their ACL and their fear of re-injury and how that affects their return to sports and their re-injury rate in the future.
More answers coming for our patients and families, which is really, really cool, really important. So as we near the end, one of the things that I just love to ask is there anything that we haven't talked about that you want to make sure our audience has an opportunity to learn from you?
I really like to bring it back to thinking about the tremendous benefits of youth exercise and youth sports, like decreased rates of obesity, better bone health, lower rates of depression, substance abuse, teen pregnancy, greater success later in life. So I think we really want to be encouraging our youth to be active and participate in sports. If I had to do anything that we didn't touch on, it would be sort of balancing the yin and the yang of injury and the benefits of youth sports.
It's worth the risk because there's a lot of things we can do to prevent.
Absolutely.
The potential of an injury. So that's really where it's key.
Yes, I agree.
That's great. Now it's time to move on to doctor's orders. And this is the part of the show where you prescribe an action that parents can take to help them raise healthy kids.
My doctor's orders with respect to ACL injury, would really be thinking about prevention. If your kid's participating in a high-risk sport, think about prevention programs, because they can help prevent ACL injuries, but also other injuries. I think, if there is an injury, my doctor order would be to get attention. Don't believe in no pain, no gain. If something's swollen, if something's painful, it needs to be seen. The goal of all of those orders is really for the long-term health of that joint. I think if we can prevent injuries, if we can treat injuries effectively, then, we're reducing the risk of long-term arthritis, needing a knee replacement when you're in your 30s or 40s. And so that's sort of the overall goal.
Yeah, no, I think that's really, really good advice. We want to prevent those long-term complications and help to support our kids to do the sports that they want to do and to enjoy it because it's so good for their physical and mental health.
Absolutely.
Well, thank you so much, Dr. Kocher. It's been such a fun conversation.
Yeah, thank you, Dr. Arnold. I really enjoyed it.
Thank you. Thanks for listening to Boston Children's Answers Parentcast. And special thanks to our guest parent, Julie, and our guest expert, Dr. Mininder Kocher. To learn more about ACLs or to listen to any of our podcasts, please check us out at bostonchildrens.org. Thanks, and see you next time.